practitioners should know about childhood cancers? Okay, so at the end of this presentation, we should all be able to at least define and classify childhood cancers. We should also understand the etiology of childhood cancers, as well as the general principles of diagnosis and management. I'll also take us through a couple of oncological emergencies and how to handle them. Then we'll talk briefly about the late effects of cancer. I also have some pictures at the end of the presentation that show the various ways that children will present to us at our health facilities. So in order to achieve these objectives, this is going to be the outline of this presentation. So by way of introduction, International Childhood Cancer Day is celebrated on the 15th of February every year. And the aim is basically to raise awareness about childhood cancer and to advocate for improved diagnosis, treatment, and care for children with cancer. And so programs such as these are what we put in place to achieve this aim. So what is cancer? Cancer is basically when a cell in any part of the body starts to grow out of control. And then you have what we call a tumor forming, which eventually may spread or may remain in the same part of the body. The Latin word for cancer means crab. And in the olden days, it was thought that most tumors had these projections like crab legs. So that's where the word came from. Now, cancer harms the body when these damaged cells form lumps or masses of tissue, which we know are called tumors. Now, a tumor may stay in one part of the body and may not grow at all or even grow very, very, very slowly. And these tumors are usually considered to be benign. However, a tumor is said to be malignant when two things occur. That's when there's invasion or when there's angiogenesis. With invasion, basically the cancerous cell moves through the tissues, causing destruction in its wake. It could go through the blood or the lymphatic system. And then with angiogenesis, as the cells divide and grow, they also form new blood vessels to feed themselves. And this is a process that we term as angiogenesis. And we say a cancer has metastasized when it spreads to other parts of the body from where it was originally located. This can happen locally from one point to the other or through the blood, that's hematologically, through the lymphatic system, and then finally end up at distant parts of the body. So a little statistics. In Ghana, approximately 120 to 140 new cases of cancer are diagnosed each year. Unfortunately, many of these children would present to us with advanced disease. And this is because more often than not, the diagnosis is not made early. It's been shown that most of these children would have presented to the health service several times over the preceding weeks or months, but because of inadequate knowledge about some of these cancers and their presentation, they are not picked up early until it's unfortunately too late. Male children tend to be more affected by childhood cancers than female. It's a ratio of 1.9:1. Now, obviously, these delays would make treatment more difficult and basically give a bad prognosis. But fortunately, the good news is that about 80% of childhood cancers are curable. The caveat is that they need to be detected early, and that's why these programs are put in place to help us broaden our knowledge about these cancers and pick them up as early as possible. So in 2020, a study was done at Komfanochi Teaching Hospital, and this is the prevalence or the incidence of childhood cancers, the highest being the leukemias, followed by lymphomas, Beckett's to be precise. We also have Wilms tumor, which affects the kidney, and then the retinoblastoma, as well as others like the brain tumors, neuroblastoma, and the rest. So to the etiology of childhood cancers, and with regards to the cell cycle process, cell division, there are 4 key types of genes that are responsible. We have the proto-oncogenes and oncogenes, the tumor suppressor genes, suicide genes, and the DNA repair genes. So proto-oncogenes are responsible for regulating normal cell growth and division. But when a mutation occurs in a proto-oncogene such that it gets activated when it is not supposed to be, we now call it an oncogene, and this oncogene will promote abnormal cell proliferation. Tumor suppressor genes are responsible for inhibiting cell proliferation and tumor formation, and also promoting apoptosis, which is programmed cell death. So when there's a mutation in these genes, and these genes are not able to perform this function, and once again, you have abnormal cell proliferation. There are also the suicide genes, which are supposed to control apoptosis. And then the DNA repair genes, which instruct a cell to repair any damaged DNA. And if it cannot, to allow itself to undergo programmed cell death. So when there are mutations to DNA, which make the cell unable to correct DNA damage and make them unable to commit this suicide, then we have this abnormal cell proliferation that will keep going on. So similarly, cancer is just a result of mutations that will inhibit the proto-oncogenes, the tumor suppressor gene functions, leading to uncontrollable cell growth. Now, these mutations in DNA, these abnormal DNA, can either be inherited or acquired. It's been shown that aging increases the number of possible cancer-causing mutations in our DNA. So the older we go, the higher the probability that some DNA may undergo some mutation and may predispose us to developing cancers. There have also been several viruses that have been linked to cancer formation, such as the human papillomavirus, HPV, hepatitis B and C, Epstein-Barr virus, and then HIV. Aside these viruses, there are also other associations which increase the risk of childhood cancers. These include things like environmental factors such as radiation, drugs, chemicals, prenatal exposure to tobacco and radiation, and the exposure to commercial pesticides used by parents, so especially with children whose parents are farmers. So we can classify childhood cancers into 5 broad categories. We have the lymphomas, which are cancers that begin in the lymph nodes and the immune system tissue. So your B-cell, T-cell lymphomas, your Burkitt's lymphomas, non-Hodgkin's, Hodgkin's, among others. We also have the leukemias, which are cancers that start in the bone marrow and then accumulate in the bloodstream. So we have your acute myeloid leukemia, acute lymphoid leukemia. We also have sarcomas, and these are cancers that arise from bone, cartilage, fats, and other supportive tissue. So like osteosarcoma in the case of bone. And then we also have carcinomas. And these are cancers that arise in the epithelial tissue of the skin or the lining of internal organs, as seen in lung cancer, breast cancer, colon cancer. And then lastly, we have the adenomas. These arise in glandular tissue, so thyroid gland, pituitary gland, adrenal gland, and others. So as is the case with all other conditions, medical conditions and diseases, the principles of diagnosis remain the same. You need to take a good history, do a thorough physical examination, do your appropriate investigations. In this case, investigations in childhood cancers are both for diagnosing and also for treatments to monitor progress. And then you eventually make your diagnosis and also stage to tell you the extent of the cancer and also give you an idea of the prognosis. So with history taken, again, it follows the same process as with any other condition. They would usually come with a presenting complaints, and you need to find out how long that symptom has been there. If there are more than one symptom, you need to describe how they occurred in chronological order to give you a better understanding of the progression of the disease. With your past medical history, you want to find out if the child has had previous admissions, because like I mentioned earlier, more often than not, they would have been in and out of hospital a few times. And so if you have a child who's been in hospital all the time, that might give you a better understanding of what is happening, and also find out if they've had to have recurrent transfusions. You also want to ask about family history of cancer or any previous deaths from cancer in the family, because you've established that abnormal DNA mutations can be inherited. And then, as we all know, pediatrics is very big on social history. You need to take a detailed social history because it might bring about things like exposure to pesticides in children whose parents are farmers, among others. So while taking a history, these are some early warning signs that we need to take note of. Some of these may be offered or volunteered by the parents. Some of these we would have to draw out of them. And so there's a nice mnemonic for it. I believe that at the end of this presentation, this is the one thing that we should at least try to remember, especially as health practitioners. So the mnemonic, once again, is child cancer. C, continued unexplained weight loss. H stands for headaches, usually early morning headaches with vomiting. They may also present with increased swelling or persistent pain in their bones, joints, back, or legs. L represents a lump or a mass, especially in the neck, in the abdomen, in the armpits, in the pelvis. They may also complain of excessive bruising, bleeding, or a rash. C, another C, which stands for constant infections. They may tell you the child is always in the hospital being managed for one infection or the other. Some may complain of a whitish color behind the pupil or a whitish color in the eye. And then there may also be nausea, which persists, or even vomiting without nausea, or noticeable paleness. E for eye or vision changes, which may be sudden and persistent. And then recurrent or persistent fevers of unknown origin. These are things we really need to look out for when we are taking a history. Another mnemonic, which is a bit more popular, which is the Saint Silouan. Saint Silouan was a Russian Orthodox monk who is believed to have prayed ceaselessly for humanity. So this mnemonic was developed and it's to help everyone remember the early warning signs of childhood cancer. So the first letter, which is S, is more of an admonition rather than a sign or symptom, and which is to seek medical help early for ongoing symptoms. I represents a white spot in the eye, or even a squint, which is the same as a strabismus, or sudden blindness or bulging of the eyeball. L represents a lump on various parts of the body, in the stomach, the pelvis, the head, the arms, etc. U stands for unexplained fever, which is persistent for over 2 weeks, or if there's weight loss, fatigue, pale appearance, easy bruising or bleeding. A represents aching bones, joints, back, and easy fractures. And then N refers to neurological signs, maybe a change in the way the child walks or their speech, or regression in their milestones, or persistent headaches with or without vomiting, or even an enlarged head. So after taking a good history, you want to also examine your patients. And the examination follows the same as we are all used to. With your general exam, you want to look for things like lymphadenopathy. You want to check for pallor, clubbing, wasting, evidence of bruising in the gums, under the skin. You also want to look at the eyes, see if you can detect any white eye or strabismus or squint or any swellings. And then you go ahead and do your systemic examinations as well, looking out especially for the liver and the spleen, which may be enlarged depending on the type of cancer. Then you want to do your investigations. As I mentioned before, these are to help with your diagnosis, but also to monitor treatment when it's initiated. So for your hematological studies, you want to do a full blood count, looking out for the cell lines, your blood film comments as well, to look at the nature of the cells, their morphology. You want to do your liver function, kidney function, as well as your electrolytes, LDH, uric acid, and others. You want to do a clotting profile. You would definitely also want to do imaging studies, your X-rays, your ultrasound, CT, and even MRI scans. And especially in the leukemias, you'd want to do your bone marrow aspirates. And then in some instances, you'd have to do a CSF cytology or cytology of any fluid that is taken from the body. And then we can also do your biopsies, your fine needle aspiration cytology, and then some immunological evaluation as well. So the general modes of management for childhood cancers include chemotherapy, surgery, radiation, biological response modifiers, or a combination of any of these. And for the purposes of this presentation, I will focus more on chemotherapy. So chemotherapy is basically the use of cytotoxic agents that target cells that are rapidly proliferating, and they typically cause cell death by interfering with DNA replication or the repair mechanisms, also interfere with cell division or even metabolic pathways. Now, there are two categories of chemotherapeutic agents. We have the cell cycle specific, can be a mouthful, cell cycle specific, and then the cell cycle non-specific. So the cell cycle specific, these are drugs that reduce the growth fraction. That's the number of cells in a cell cycle. And this is usually, or these drugs are usually given in divided doses or as a continuous infusion. Then with the cell cycle non-specific, these drugs aim to reduce the tumor burden. That's the number of cells in a tumor. And these are usually given as a bolus. But it is worth noting that to achieve maximum tumor cell kill, the cell cycle specific and cycle non-specific drugs are given in combination to both reduce the growth fraction and then also reduce the tumor burden. So this combination is usually given in courses, or what we say, or what we usually term as cycles. And the number of cycles vary depending on the cancer type, the chemotherapeutic agent you are using, and also the patient's response. So there are several treatment strategies that are employed in the management of childhood cancers. And we have the adjuvant strategy or therapy, which is basically where you give a short course of high dose, usually combination drugs, but you give these after some radiation or surgery has been done. With neoadjuvants, as the name implies, the drugs are given pre-op, that's before the surgery is done, or sometimes perioperatively. And the aim is basically to shrink the tumor or to reduce the tumor load or the tumor burden. With hematological malignancies, there's usually the induction phase where a combination of high-dose drugs are given to induce a complete response when you're initiating a curative regimen. And then after your induction phase, you do a consolidation phase, which is usually given after the induction phase has achieved a complete remission. And then this is to increase the cure rates or prolong survival. There's also the intensification phase, which is after complete remission is achieved. So the same agent that was used in the induction phase or even a different agent is given at a high dose to effect a better cure rate and a longer remission. And then there's a maintenance phase, that's where you give a single or even a combination low dose. And this is given on a long-term basis when they are in remission to delay any regrowth of residual cancer cells. Unfortunately, some of these strategies are not curative. So as in the case of palliative, it's done just to prolong the life of the child or even control symptoms in cases where we know cure is not possible. And then there's also the salvage strategy where high doses are given when symptoms have recurred or treatment has otherwise failed with another regimen. So as I'm sure we all know, chemotherapy comes with its own side effects, both short-term and long-term. I think one of the commonest we are all aware of is the alopecia. And there's also anorexia, nausea and vomiting, gut mucosal damage, and these would in effect lead to undernutrition because child will not be able to eat well, will not be able to absorb nutrients properly. There's also immunosuppression, which will lead to infection. And then there's bone marrow suppression, which will lead to a reduction in all the cell lines. So you have your anemia, your thrombocytopenia and bleeding, as well as your neutropenia. And this neutropenia would also predispose this child to developing infections. Some long-term side effects with the various medications available. Doxorubicin is known to be cardiotoxic, cisplatinum ototoxic, neurotoxicity with vincristine, hepatotoxicity with dactinomycin, and then pulmonary toxicity with bleomycin. Etoposide can predispose a child to actually developing secondary malignancies as well. So it is no news that chemo comes with its side effects, but at the same time, it is still also very effective in curing these cancers. So we'll now take a look at some oncological emergencies because we would meet children who would come either at the beginning of their disease or even when they are being managed or even after. So the emergencies may occur at an initial manifestation of the cancer or as a consequence of treatment, or it may develop at a time when the cancer is supposed to either be in relapse or it's even progressing. So there's some of these emergencies include tumor lysis syndrome, hyperleukocytosis, febrile neutropenia, superior vena cava syndrome, and mediastinal masses, neurological emergencies, and then acute abdominal emergencies. I will talk on the boldened ones, so tumor lysis syndrome and febrile neutropenia. So tumor lysis syndrome is a pattern of metabolic abnormalities that results from a spontaneous or even treatment-related tumor necrosis. So the features include hyperuricemia, hyperkalemia, hyperphosphatemia or hypocalcemia, or even a hypercalcemia, and also renal failure. You need 2 or more abnormal lab values in order to diagnose tumor lysis syndrome. And it's a very serious emergency. And if it's not treated successfully, it can lead to the development of arrhythmias, seizures, coma, DIC, and even death. So a preventative measure is to hyperhydrate, to keep the child hydrated at all times, and also to administer allopurinol or urate oxidase. We also give aluminum hydroxide to help with the phosphate excretion in the case of the hyperphosphatemia. You also need to treat any symptoms resulting from hypercalcemia. And you also need to consider dialysis if there's progressive renal failure, your renal failure is not improving, or if you have a potassium of greater than 6 milliequivalents per liter, or a phosphate of more than 6 milligrams per deciliter, or if there's oliguria or even anuria, if there's any evidence of volume overload, or if there's symptomatic hypocalcemia, all these are indications for dialysis. The next emergency is febrile neutropenia, which is when you get a temperature recording of 37.5 degrees Celsius, more than 37.5 degrees Celsius on 2 occasions, measured 30 minutes apart, or a single reading of 38.3 degrees Celsius in the presence of some level of neutropenia. So these are the values stated there. If neutropenia is considered when there are less than 1,500 cells per cubic millimeter, moderate 500 to 999, and then profound neutropenia is when you have less than 100 cells per cubic millimeter. So the management of febrile neutropenia, you need to pay very prompt attention to the child. You'd have to take cultures, blood cultures, urine culture, urine analysis, culture any lesions that the child may have, do a chest x-ray as well, and start your empiric antibiotic therapy. So you need to choose an antibiotic that will cover both gram-positive and gram-negative organisms, and you should consider your hospital's drug resistance patterns. So it's not a one-size-fits-all. You need to consider what works in the facility you're working with based on evidence. So examples of some antibiotics we typically would use are ceftriaxone, Cipro, Flucloxacin. You may do a combination of these, or you may do monotherapy, in which case we would prefer you do the 4th generation cephalosporins or the carbapenems or vancomycin. When you are managing a child with febrile neutropenia and it's persisting for more than 4 days, you need to consider that it may be a fungal infection. You also need to think about viral infections and tuberculosis as well, because the immunosuppression that comes from the cancer or even treatment of cancer will predispose them to such infections like TB. So some infection precautions that need to be taken, not just in the management of febrile neutropenia, but generally when taking care of children who have cancer. All people or all persons that come in contact with this child need to perform good hand hygiene before entering and after leaving the patient's room. We encourage what we call a neutropenic diet, that's well-cooked foods, to reduce the incidence of any foodborne infections. We also emphasize maintaining good oral hygiene. So we need to brush this child's teeth twice a day using a soft toothbrush. We don't want to use a hard toothbrush to cause any bruising or worsen any bruising that's already there. and also rinse the mouth at least 4 times a day. We encourage daily showers or baths, daily inspection of the skin sites, that may be portals of infection to the perineum, any sites of IV cannulation. You also want to avoid rectal procedures as much as possible because you don't want to cause any tears in the rectum or in the anus that would further predispose them to infections. And for that same reason, you also want to prevent constipation, because when there's constipation, there's a risk of anal fissures forming. And again, that will predispose them to infections. And very importantly, as health workers, we need to be antimicrobial stewards and not abuse antibiotics, and use the appropriate antibiotics for the appropriate infections. So, late effects of cancer. I included this slide in this presentation because a child with cancer is going to have issues for quite a while. It's not just when the disease or even just during the treatment, but even when they go into remission, they may still suffer from some consequences. So late effects are basically any physical or even psychological outcomes that develop or persist beyond 5 years from the diagnosis of cancer. Chemo, radiation, surgery may also cause late effects themselves. And some late effects of therapy identified during childhood or adolescence may resolve without consequences, while others may become chronic and even progress to become adult medical problems. So this is a table listing the various types of childhood cancers we have and some of the potential late effects. So with leukemias, they may develop neurocognitive effects, secondary malignancies, even cardiomyopathy, with Wilms tumor. Obviously, there may be kidney damage, even scarring, and inhibition of growth. Hodgkin's lymphoma can also predispose to secondary malignancies, to hypothyroidism, abnormal growth, and maturation. Still on the late effects, the list is not exhaustive, but brain cancers would obviously predispose them to having neurocognitive effects later. Bone tumors may lead to the need for amputation or even disfigurements. And same with soft tissue sarcomas as well. So with these in mind, we need to know that these children need to be screened regularly, even after you treat them for the cancers. So they should be screened 3 monthly for the first 2 years, and then 6 monthly for the next 2 years. And then you see them yearly afterwards. You may consider stopping follow-up if after 5 to 6 years, they don't have any issues every time you screen them. But you should always make sure to investigate for the potential late effects. Okay, so these are some pictures showing the certain types of the cancers we have and the way they may present. So there's Burkitt's lymphoma, that's a very bad jaw swelling. We see here, we also see leukocoria, which is a white eye. That's usually indicative of a retinoblastoma. And then beneath that, we see a child with frank retinoblastoma. As I mentioned before, they usually would present in these late stages. And we also have a chloroma there, which is a type of a myeloid sarcoma. We also have something we call leukemia cutis, which is basically when neoplastic white cells infiltrate the skin. And then we have a strabismus or a squint. And we also have some lumps in the armpits. We see there probably a lymphoma, lymph nodes in the neck. We see a child with a distended abdomen, probably has an enlarged liver or a spleen, even maybe some ascites as well. And then they may also present with bleeding into the gums as seen. So this brings us to the end of this presentation. These are my references, and thank you.
Excellent. Thank you very much. And thank you for sticking within the time and giving us so much to consume in about 30 minutes. So the floor is open for questions, for comments. If you want to do such, kindly put your questions in the chat box, or you can electronically raise up your hand, I will mute you, and then you go ahead with your questions. So whilst we're waiting for any hands that are up, I will just go through the chat box and read what we have there by way of questions. I think the first one comes from Abdul Rahman Bayo. So he says that the presenter mentioned viruses such as Hep B, hepatitis B, and hepatitis C, and then the human papilloma virus and HIV as being linked to cancers. Was that a broad statement, or there's an observed uptick in childhood cancers linked to these viruses? So Dr. Now or Dr. Matilda, I know if you want to respond to that.
Okay, so okay, Dr. Matilda, please go ahead.
Yes, so these particular viruses, good afternoon to everybody, and thank you for joining. These viruses that were mentioned have not been shown to cause any increase in some cancers in children, but they are linked to specific type of cancers, which are well known and well documented. It's not something we have observed to cause a rise. For example, Hep B and Hep C are known to cause hepatocellular carcinomas and then sometimes hepatomas, which are not very common in children, but we do see they are not part of, as you see the statistics that she presented, those cancers are not part of the very common ones, but we do see. We have the other cancer, the human papilloma virus, we know is linked to cervical cancer, which is also well known and documented, but it's not linked to a rise in pediatric cancers.
Great, thank you. So it's a general thing, even in adult medicine as well. We encounter more of the hepatomas or hepatocellular carcinomas from hepatitis B, more especially in northern Ghana, and then hepatitis C, also very common in northern Ghana, but even throughout the developed world, where injection drug abuse is commoner than in the developing countries. I think our last two presentations dealt so much with human papilloma virus, where Dr. Gildas and his team took us through cervical cancers as well. And of course, we know that HIV is linked to a couple of other cancers, like if it comes into my head, I'll probably mention it. But I remember a couple of other cancers that are linked in HIV. So these are general things that she's probably mentioned as well, and not specific to childhood cancers. All right, so the next message is from Salom. He says, excellent presentation. Rafiq says, thank you for the presentation. Pfizer says, beautiful presentation. Nusrat, thank you for the presentation. So I see there are no questions, but yeah, so one from Richard Puzaso says that in this season, how do we differentiate the suspicion of meningitis aside the postural signs of meningitis? Yeah, I think that's out of our presentation for today, but since it's come up, I think one of the key things we are looking at presenting on is meningitis, especially in this season, like you rightly said. I don't know for pediatrics, but for adults, we have the typical signs that they come in with. The presentation of a fever, neck stiffness, neck pain. In this season, with headaches, you should suspect meningitis, and then usually in your clinical examination, you'll find that those signs that you may have seen in the books, you tend to find a couple of them there, like the Penix sign, and then typically they also tend to have like the fever demonstrated that you would pick up. And then typically when it's that way, we would say that you do a lumbar puncture and then commence treatment immediately. If in the advent that you can't do a lumbar puncture, it's better to treat empirically. You don't wait till whilst you could have easily treated it. Mind you, a couple of the strains of meningitis are not responsive to the vaccines that we have. So it's better once you suspect it, you do your clinical features, you go ahead and then you can start treatment. That's out of the context of this presentation. But if that answers your question, that's good enough. And thanks for bringing it up, because it's one of the presentations we will be doing. Then Mark says that thanks for the concise presentation. Please, you mentioned strabismus towards the end of the presentation. How is this related to childhood cancers? Okay, so Dr. Na or Dr. Matilda, if you can pick that.
So strabismus or a squint, they can be used interchangeably. It's one of the signs that you would see. It's usually indicative of some problem in the eye. So in this case, maybe a retinoblastoma. So the point is that if you see a child with a squint or a strabismus, in our setting where people tend to make fun of things, it shouldn't be something you would just brush off, because it may be an early sign that there may be a retinoblastoma or some other cancerous lesion in the eye forming. I hope that answers your question.
All right, great. Yeah, so I think Richard is thanking you for the feedback, and Rita is asking, please, can we get the presentation after? Yeah, so this is being recorded. We'll put it up on the Ghana Medical Health YouTube page. You can have access to it at any time that you want to. Dr. Na would send me her slides as well, that then we can put up as well. So any of those options that you want will be readily available to you, Richard. Rita. Yeah, so Richard, you can go ahead and ask your question. I see your hand is raised. I've asked you to unmute yourself. Please go ahead. Hi, Richard. Who's Zazo? I've asked you to unmute yourself.
Hello. I think my question has been answered. Thank you.
Oh, okay, thank you. All right, because your hand was still up, probably I'm sure it is a legacy hand, so for you. Okay, so any other question? If you do, kindly electronically raise up your hand and then I'll unmute you to talk. Dr. Matilda, whilst we wait for any questions, either in the chat box or through anyone wanting to speak, do you have any concluding remarks?
Okay, thank you very much. I would like to say that we are lucky in pediatric cancers. Majority are quite responsive to chemotherapy and other modalities of management. And unfortunately, in Ghana, our survival rate is still hovering around 20%. Whereas the advanced countries are doing very well, they are getting cure rates up to 80%. And so we are still losing a whole lot of our children that we are diagnosing of the various types of cancers. And the issue has always been the awareness level. The awareness level is not just with the population, but health workers in general are also part of this low awareness, such that these children will present to peripheral facilities several times. They will go, they will treat as infection, they go, they treat at all manner of things. And we see them, we get to diagnose them finally very late. And that is greatly affecting the outcome that we are getting. So I think every health professional should take it upon ourselves to update ourselves, educate ourselves, and learn more about cancers in a way that when you see a child, you are able to make diagnosis promptly and refer appropriately so that treatment can begin. And this will raise our treatment successes. That's what I have for you. Thank you.
Great, thank you very much, Dr. Matilda. I don't see any hand up. And some few messages on the chat. I think the last one came from Salifu Rafik. Can I get the link to Ghana Medical Health? Okay, yeah, so I would just put that up so that if you want to download those presentations, you can. So if you check in the chat box, I just did that. And then Salom say, how far are presentations for the Upper West Regional Hospital towards the commencement of oncology services? Dr. Matilda, do you want to respond to Salom on that? The commencement of oncology services.
Okay, I mean the process is ongoing. The management, together with some pharmaceutical company, with our pathologists, are working hard to establish this, and we believe that this year we should be able to start that service.
Fantastic. Thank you so much. Yeah, so I just want to say thank you to all of us for joining today, and a big one and special thank you to Dr. Now for an excellent job done. We've been able to do this in less than 30 minutes, and we've had some good time to discuss. And obviously, I don't see any hand up, meaning there's no much to be discussed again. Either we all understood everything, or hopefully not the other side. So next week, hopefully, we'll come your way with another presentation. We say thank you for joining us, and thanks to the pediatric team for enlightening us on childhood cancers. Just by way of announcement, like I indicated a couple of weeks ago, and last week as well, there are open slots for presentation. If you've learned something new that you want to share with us, we are glad to host you to do that. Kindly let me know, and then we can plan for you. We usually give a stipend of 500 Ghana cedis for each presentation. So till we come your way next week, kindly take good care of yourselves, and God bless us all. Let's continue to educate and teach each other and make the world a better place. Thank you, Dr. Matilda. Thank you, Dr. Na, for an excellent job. Bye-bye.